And now we're going to give the microphone to Professor M.OSTERMANN, who is going to talk about how to prevent and to treat perioperative AKI. Professor M.OSTERMANN is a well-known nephrologist and intensivist working in London. Marlies?
Thank you, Tom. Good afternoon, everybody. It's a great honor to contribute to this important meeting, and I would like to thank the organizing committee and in particular Professor RIMMELE for inviting me. Here are my disclosures, and they have not influenced this presentation. As Professor Bell and Professor Kellum elegantly outlined, acute kidney injury is a common complication after surgery, and there are so many reasons as just outlined in the previous talk. And the risks depend on the patient profile, but also the type of surgery. In recognition of the impact of acute kidney injury, the steering committee of the Acute Disease Quality Initiative and the Perioperative Quality Initiative called a meeting in September 2019 to review the current data and to develop some guidance for clinical practice. The meeting was held in the UK with representation from different specialties, all involved in the care of patients undergoing surgery, and representatives from different countries. And the expert committee recognized and acknowledged that patients undergoing surgery go through different phases, all of which provide opportunities for intervention and opportunities to prevent acute kidney injury. And it really starts with the preoperative phase. And the expert committee recommended that high-risk patients should be identified through a preoperative kidney health assessment. And the recognition of high-risk patients offers not only opportunities to inform the patient, but also opportunities to identify strategies for prevention and modify clinical practice. And with regards to these opportunities, the team issued a guidance to discontinue ACE inhibitors and angiotensin receptor blockers at least 24 hours before surgery. And this guidance was based on the fact that hypotension is a common risk factor and contributor to acute kidney injury. As an example, I just show you a systematic review with data of 42 studies published until 2017. And when you look at the combined data as shown here, then organ injury, including acute kidney injury, was a highly prevalent complication and was highly prevalent in those with severe hypotension and prolonged hypotension. So severity of hypotension and duration of hypotension were independently associated. The lower the blood pressure and the more prolonged, the higher the risk of acute kidney injury during surgery. Professor Shaw and other colleagues also looked at hypotension during the post-operative period and found a similar association. They analyzed data of 67,000 patients who had undergone a non-cardiac surgical procedure and had not had any problems with hypotension during the surgery, during the intraoperative period. And when they looked at the post-operative period, they noticed that post-operative hypotension was not only common, but also associated with acute kidney injury. It was particularly prevalent in the first 4 hours, and the exact incidence really depended on the definition used for hypotension. But whether you use a cutoff of 55 or 65, as shown here, post-operative hypotension was an independent risk factor for the development of acute kidney injury in the following 7 days in those who had not had hypotension during the intraoperative period. Now, this is important because you can probably do something about this, and the fact that intervention is effective was shown in several studies, including the IMPRESS study. The IMPRESS study explored and investigated whether individualized blood pressure management tailored to the individual patient was effective at reducing the risk of acute kidney injury. They randomized almost 300 high-risk patients undergoing major surgery to a blood pressure which was within 10% of the resting systolic blood pressure versus management only if systolic blood pressure fell to less than 80 millimeter mercury. They achieved good separation between the two groups. Patients in the individualized group indeed had a higher blood pressure throughout the perioperative period. And this intervention resulted in a reduction in acute kidney injury. Patients who had been treated and managed in the individualized blood pressure group had significantly less acute kidney injury. It was predominantly early acute kidney injury, so in the risk group. With that in mind, the expert group attending the meeting in Cambridge recommended that the intraoperative mean arterial blood pressure should be maintained above 65 throughout surgery to reduce the risk of acute kidney injury. They acknowledged that individual patients may need a higher blood pressure, for instance, patients with chronic hypertension, and that individual management was necessary and should be initiated based on the individual patient risk profile. Now, the next important component during surgery is obviously fluid management, and Professor Kellum has already alluded to this. Hypovolemia, but also hypervolemia are harmful to kidney function, and hypervolemia, as Professor Kellum said, can cause acute kidney injury and contribute to acute kidney injury. With that in mind, the question is, can you prevent acute kidney injury by reducing fluid administration? And this was tested in the RELIEF trial, which Professor Bell already mentioned, a large randomized controlled trial conducted in Australia and New Zealand, where patients undergoing major surgery were randomized to a fluid restrictive versus liberal fluid strategy. And indeed, they achieved good separation between the two groups. Patients in the restrictive group received significantly less fluid compared to the liberal group, but at 1 year, there was no significant difference in survival. However, patients who had been randomized to the restrictive group had a much higher incidence of acute kidney injury, and significantly more patients needed renal replacement therapy. And with that in mind, the expert group recommended against the use of a restrictive zero fluid balance in major elective surgery. It was obviously recognized that hypervolemia is also harmful, but the recommendation was against a zero balance fluid regime. With regards to the type of fluid, the expert group did not have sufficient evidence to make a recommendation on the use of colloids versus crystalloids. But when using crystalloids, they recommended to use balanced crystalloids over saline. And again, Professor Kellum alluded to this. Now, this recommendation was developed in 2019, published last year. Now, obviously, since then, we've had more fluid trials. We've had the BASICS trial and the PLUS trial, both showing no significant difference between balanced fluid and saline group. And this led to an update of the meta-analysis, including the data of the BASICS and PLUS trial. Importantly, these were critically ill patients, not just surgical patients, but they all included surgical patients. And in this updated meta-analysis with more than 35,000 patients, again, there was a clear benefit seen in the balanced fluid group. Patients who the estimated effect of balanced crystalloids versus saline ranged from a 9% relative reduction in death and acute kidney injury to a possible 1% relative increase in either death or AKI, still supporting a guidance in favor of balanced solutions. The next important component of perioperative management is goal-directed therapy, and this has been studied in more than 100 randomized controlled trials. This group from Italy performed a meta-analysis and included 65 of the 126 available randomized controlled trials using strict inclusion criteria, and clearly showed that goal-directed therapy compared to control was associated with a reduced risk of acute kidney injury. When they looked at the different types of goal-directed therapy and compared goal-directed therapy with fluids alone versus goal-directed therapy using fluids and inotropes, there was a significant signal, again, in favor of a strategy using fluids and inotropes. And with that in mind, the expert group recommended the use of goal-directed hemodynamic therapy to prevent post-operative acute kidney injury. The team looked at numerous drugs that have been used to prevent acute kidney injury in the surgical setting, but there was no evidence to support any of these drugs to prevent acute kidney injury. With regards to prevention of acute kidney injury during the post-operative phase, the expert team recommended, similar to the intraoperative period, to maintain euvolemia, to prevent hypo and hypervolemia, and to correct hypotension as quickly as possible. They also recommended to prevent or correct hypoglycemia as quickly as possible. Now, acute kidney injury can obviously occur despite the best prevention strategy. And if it does occur, then it should be managed with the idea to prevent progression. The expert team looked at existing studies and felt that the existing KDIGO recommendations for the management of AKI were all applicable to surgery-associated AKI, and therefore recommended to use balanced solutions over saline, to use vasopressors to support and correct vasoplegic shock, and to use a protocol-based hemodynamic optimization. For the post-operative period, they issued a particular recommendation, again, to emphasize that AKI is never the same and that different patients have AKI for different reasons, and it's important to do some diagnostic workup and identify the underlying cause so that management can be guided accordingly. And lastly, the expert group looked at renal replacement therapy in case AKI progressed to a more severe stage. And the team, after reviewing the literature, recommended that the decision to start kidney replacement therapy should be based on either anticipated or observed life-threatening complications, rather than starting preemptively. I realize what I've shown so far is all related to non-cardiac surgery. And for completeness, I'd just like to show there are obviously also guidelines in the literature to prevent acute kidney injury after cardiac surgery. Just as an example, here's the most recent joint guideline to prevent cardiac surgery-associated AKI. Again, an emphasis on correction of hemodynamic instability and maintaining hemodynamic stability. And with that, I'd like to finish. I want to emphasize that pre-operative, intraoperative, and post-operative strategies are available and effective at preventing perioperative acute kidney injury. And the emphasis is really on recognizing high-risk patients, maintaining an adequate blood pressure, preventing hypotension, and preventing hypo and hypervolemia. At present, we have no specific therapies. Every glomerulus matters and needs to be saved. And with that, I'd like to finish and thank you for your attention.
Well, thank you very much, Marlies. We have time for one or two questions. There is one question because this is important. We have many clinicians online here, and they understood that when there is just a little bit of fluids administered in the operating room, it doesn't matter that much if you give saline or balanced solutions. However, when there is a large amount of fluids administered intraoperatively, then it matters much more. And one of the questions is, what's the threshold? I mean, is it 1 liter, 2 liters, 3 liters? Any data on that, or we don't know?
I think the amount of fluid to be given obviously depends on the severity, on the individual case and the duration of surgery. And amongst experts discussing this topic, it was felt that aiming or keep allowing the fluid balance, there was an emphasis on making sure that clinician kept an eye on the fluid balance, i.e. what was going in and was coming out, and that a fluid balance up to plus 500 was in keeping with the current guidance, in keeping with the fact that patients have insensible losses, and in keeping with the fact that patients that some fluid, a slightly positive fluid balance may be necessary to correct pre-existing hypovolemia. So plus 500 is the general feeling. But this has not been tested, in fairness.
Okay, thank you very much. Last question regarding the intraoperative hypotension. We know that it's both the severity of the hypotension and the duration of the hypotension may be important. Which one, according to you, is the most dangerous?
The honest answer is I don't know. I'm not sure. So the studies which I've seen, I showed you the systematic review. I've also seen individual studies. They showed that even short periods of a blood pressure less than 60 or less than 55 millimeter mercury were dangerous, but I don't know which one is more nephrotoxic. I suspect it will also depend on the patient and whether they had pre-existing hypertension or not, but I'm not sure.
Okay. Well, Marlies, thank you very much for your participation to this meeting. We are very happy to have you.